Hello, good morning. Can you hear
Good
me?
morning.
Yes. Okay.
Yes, not only hear you, we see you actually.
Okay, thank you. And thank you, Edward Grube, S.J. Bach, and many distinguished panel in the world. And we're going to start the first live case. And welcome everyone to join this year EpiValve Structural Heart Disease meeting. So, and today we prepare the first case, very debatable case, low risk, relatively young, the TAVR patient. First, I'm gonna introduce our team. And the first operator, he's Professor Jin Kim. He's cardiac surgeon. And the first cardiac surgeon got the TAVR proctoring. Only one cardiac surgeon got a TAVR proctoring in our nation. And Professor Kim, he's echocardiography specialist, and Professor Kang, and he's our intervention cardiologist and fellow. Park, and he's the senior fellow, and me, D.W. Park. So we're gonna start the patient presentation, and Professor Kang, can you explain the patient background?
Yes, our first patient is a 71-year-old gentleman admitted for dyspnea. He had a history of diabetes, and his echocardiography showed severe degenerative aortic stenosis. He had no other medical history before. Next. And his STS mortality score is 1.06%, and Euro score is 0.76%. So it's very low risk patient. Next. And his echocardiography showed normal ejection fraction, and peak and mean pressure gradient was 86 to 57 mmHg, and there's no another findings. And coronary angiogram showed mild stenosis. And next. And EKG showed normal sinus rhythm. Next. And chest X-ray showed non-significant finding. Next. And we comprehensively evaluate the CT from this patient. And annular short diameter was 22.8 millimeter, and long diameter was 28.5 millimeter. Annulus area was 488 square millimeter, and perimeter was 79 millimeter. Next. We also evaluated the size of sinus valsalva. The area was 871, and the sinus to annulus area ratio was 1.78. And the ST junction size was 709 square millimeter, and the size was sufficient when compared with the annulus area. Next. And LVOT does not have significant landing zone calcification, and also LVOT area was 476. Next. And this is the amount of calcification, and total amount of calcification was 512 cubic millimeter, and the calcification was in NCC and RCC mainly. Next. And this is the shape of calcification. You can see that there is no significant calcium chunk in alveotic landing zone. Next. And coronary height was over 16 millimeter and sufficiently high. Next. And we evaluated the iliofemoral artery. And next. And aortic arch that showed no significant plaque or stenosis. Next. And this is the sizing chart for SAPIEN 3.
So, and on the basis of the sizing chart, and we decided to put the SAPIEN 3, and usually our targeting is 10%, 15% oversizing. So we initially planned to put the SAPIEN 3 26 and 2 cc oversizing initially, and then checking the echocardiography, hemodynamics. If PVL was significant, we're gonna do additional balloon dilation. So, and Dr. Kim, can you comment on the pre-echocardiographic finding?
This is Dilation from Asan Medical Center. Can you see the echo image right now?
Okay.
Okay.
Yes.
This patient is slightly obese. Unfortunately, as you can see here, the echo image is not good. This is a parasternal long axis image. The LV function looks good, and you can see a severely stenotic aortic valve. Next. This is a magnified view. No AR was noted. Next. 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 This is short view. Because of the limitation of a window, we cannot recognize the exact morphology of the aortic valve cusp. Next. Next. This is an apical view. The airway function looks good. There is no regional wall motion warranties. Next. The CW tracing signal is very poor. At the highest gain, you can see your peak velocity was 3.2 meters per second, indicating severe aortic stenosis. Okay.
Okay, so I think this patient is very debatable portion at this year SEC late-breaking trial, partner 3, and low-risk Evolute trial was published, and so in the reality, there is a definitely paradigm change. So among the panelists and the 2 cardiac surgeons, Jae-won Lee and Jian Ye was participate. I think this patient is very nice, the debatable portion to discuss how much do TAVR procedure in low risk and how much younger patient would be eligible for TAVR procedure was good debatable portion. And this procedure we're gonna come together with our cardiac surgeon and the interventional cardiologist. Okay, any question for patient? The history and background?
Thank you very much. It's a great case, and obviously we have a wonderful panel here. Any comments from the panel as far as the indication is concerned, as far as valve selection is concerned? Anything, Professor Kim? He's looking, always thinking.
Yeah, the issue is not low surgical risk, but age. So 71 years old male. The classification is very little and very easy case for both surgery and TAVI. Thus, we can choose any procedures considering the durability of the valve, TAVI and SAVI. We now acknowledge the durability of TAVI valve leaflet would be compatible to surgical valve leaflet. In this context, we can choose either way, but we have many surgeons who strongly recommend surgical AVR for younger patients, such as patients' age is less than 75 years old. Thus, it is really hot debate in this case. How about Eberhard? How about your opinion?
Yeah, I think I fully agree with what you say. I think what is important to note that we shouldn't be overdoing and interpreting the low-risk situation, even though it was an important trial. But I mean, the low-risk trials, obviously opened the gate to the low-risk situation. But let us not forget one thing: the inclusion criteria, or let us say the exclusion criteria for the low-risk trial, TAVR trial, was not really an all-comer low-risk trial. All the potential problems for TAVR, like calcifications, bicuspid valves, have been excluded from the low-risk trial. So I don't think, even though it was an important trial, obviously, it is not like now the door is open and we can do everything. So I really think what's been said is important, that we have to consider the long-term situation in young patients and the low-risk situation. I think it is very appropriate. Here, I guess you can do it either way, at least in my view.
Okay. Eberhard, I want to just, I have a simple question to surgeons. There's James here, Dr. Jae-won Lee is here, so why don't you come on here, Dr. Lee? He's surgeons, I want to just ask one simple question. 71-year-old man and severe aortic stenosis in the surgical side. Do you want to choose a mechanical valve or, bioprosthetic valve? Just a simple question, James. For these patients, do you want to choose a mechanical valve or a tissue valve?
Is this the young man with the gray hair?
I'm not sure it's so young.
We know what valve he's taking.
So which one?
I think I agree with Dr. Grube and Dr. Kim's comments, and then partner 3 tries a low-risk patient. I agree it's not all coming this kind of AS patient. So for this patient, typically, is I think is in the partner 3, this trial range, and the partner trial is average about 79, and this is 71. I think within the range.
So my question is, that, as a surgeon side, do you want to, for particular this patient, do you want to choose a mechanical valve or tissue valve?
Tissue valve, of course. This
Tissue valve.
71, I
Alright.
think for me, my practice is
Or
60, 65 is sort
what
of a
about you,
borderline.
Dr. Lee?
딱
He
잡아.
says he definitely choose tissue valve.
Tissue valve. Oh, the surgeon side, you choose a tissue valve, right?
되세요.
So I truly, that Dr. Kim already mentioned about the longevity concern, durability concern. However, if you want to choose the tissue valve, based on the current data, partner 3, etc., etc., is that TAVR wins, right?
자, 프리볼론.
Do you agree that one? No, James.
자, 프리볼론 줘보세요.
Why not? It's the same
I
tissue
guess
valve.
this is
it's the same.
debatable whether type of wing or just the equal or similar or the.
그다음 밸브 다 준비하세요.
So I think this case, I agree. I think either one is feasible. I think in my practice, I will ask a patient to discuss openly about the TAVI and surgical like advantage and disadvantage. And I think a patient decision is really important in the part of decision making. That's my opinion.
테스트.
In
한번
low
테스트 해볼까?
trial,
자,
the
패시몬.
use of less invasive
마스터.
thoracotomy,
오케이.
less invasive thoracotomy
여기
approach
발전 끝나면 시작하자.
may have equal or more effective than TAVI. That is true.
Horst,
I think
what do
it's
you think?
I think it's difficult to discuss with the patient when we don't know what to recommend, and how should the patient then decide. But I would clearly go for TAVR here, not for surgery, definitely. And I would recommend TAVR and not surgery. I mean, this patient that is 71 years old. He would fit very well into the low-risk trials. I think the mean age was 78, so I don't see anything against TAVR here.
Hey,
Done by a surgeon. Done by a surgeon.
No, I think we have to be fair. I mean, if we are 71 years old, and I think whether it's going to be 65 or 70, you know, it's personal preference. There's nothing that would support either way. But I think what we have to be careful about, there are two things that worry me a little bit. Number one, the surgical move that they try, in my view, surgeons should maintain their experience and their way of looking at things, because it has been a very successful journey for them. If they try to mimic TAVR with stentless valves, for example, then the questions that they were asking us will bounce back to them, from us to them. Do you have any data that would support long-term data that would support the use of stentless valves? The use of stentless valves, so in order to be a little bit more compatible with TAVR, I don't think is the right approach. I understand the field has to move, but I don't think that, you know, we should try to get the disadvantages of either one approach, and I think we have to be careful and do what we think is right for the patients, but we shouldn't overdoing it, not us pleasing the surgeons or the surgeons trying to please us, and then dealing with the same downsides.
Okay, so and we're gonna do and pre-dilation and these patients
Long
calcium.
terms here, but
Okay.
I'm glad that you keep on working. Actually,
Okay, got it. 조금만 더. Okay, test.
pre-shaped wire.
Okay. This is the Safari, the small. 자, okay. 자, 우리 김호준 선생님 말만 들으세요. 자,
Facing on.
Okay, this is a 20. Okay, deplete, facing off.
What size of the balloon?
This is a 20, and our strategy is this is a 26. So we're gonna plan, and usually two downsizing pre-dilation. Our protocol usually depending on the calcium criteria, less than 400 millimeter scale, we're gonna do direct stenting, more than 400, and we're gonna do pre-dilation. And you know, this doing or not doing pre-dilation is different according to the physician preference or experience. This is a Sapient 26. 자, keep the wire 잘 보고. Okay.
So
Now,
can I ask the panel who would
Okay.
pre-dilate and who would not pre-dilate? Could you raise your hand who would not pre-dilate? Okay. So majority would not pre-dilate, but anyway.
Okay. Okay. This
You
is
know,
23.
this case is very provocative, and this is not a low risk, very low risk patient. So the result should be perfect.
The reason why
And
cardiac
the
surgeon doing
operator is a
TAVR.
surgeon, pretty sure is a
자,
complete
김원진
treatment.
교수가.
Depending on the cardiac
Factory
surgeons, operator.
네. 그래서 자, 내가 할게.
Well, let me propose the next
자,
question.
잠깐만.
For a very low risk, 71 years old.
저 와이어 잘 봐. 와이어만.
Valve
보입니다.
choice, any difference in terms of selection of the valve?
자,
In case the patient
okay.
has, degenerative change 10 years down the road or 15 years down the road,
오케이.
and you
잠깐만.
have to do
한번
valve in
풀고.
valve again with balloon expandable versus valve self-expandable.
It's
Be any difference?
always dilemma. In terms of durability, if effective aortic failure is very
됐다.
important,
자,
in
천천히
that
올라가자.
EOA aspect, we
만들고.
prefer Avultal
조금
than
만들고.
to Sapien.
Okay,
But
great.
considering future coronary PCI intervention or future V-TAVI, then Sapien 3 would be preferable. Thus, it
자,
is
여기서
always
한번 그
kind of
플라나뷰 맞춰볼까?
trade-off. How to select
플라나뷰지?
valve type in such kind of
Okay,
long
자.
life
들어가
expectancy?
봅시다. 들어가겠습니다.
Well, I think the points that you raised are obviously the most important ones. The younger you are, the more you have to look for
오케이, 됐어.
secondary issues like PCI access, and for that, I would probably use a Sapien here,
엑시스 is
because if
good.
there is an issue with coronary access, then we really have a problem.
자,
But now they're deploying the
테스트.
valve, and maybe we can
우리
have
저기
a look
마취를
here.
조금만 더
You're doing the
안 움직이게 해주세요.
50-50
조금만 더
approach?
누르면 되겠다. Yeah, this is the 50-50 approach. Okay.
But you are going
자,
to do
테스트.
2 cc overfill,
Yes. Okay, 조금만 더 들어. No, we're gonna usually do
so a little
50-50.
bit lower.
Diameter size
Okay.
was 27 something, right? However, percent
Okay,
area
괜찮다,
percent
그지?
stretching is
자, 요거지 요거.
15%.
이거.
Usually 15% oversizing in Sapien 3 would be kind of concern, considering the aortic tear, such as at ST junction
잠깐
or under
천천히
tear.
차분하게.
But in this
자,
case, calcification is very little, and ST junction height
조금만
size
더
is
들어가고
very
싶네.
tall and wide, no
그렇지.
calcification
오케이,
at ST
됐어요?
junction.
Great.
Thus, it is
오케이,
very
됐다.
low
다이
chance of
괜찮지?
aortic
자,
tear.
김우진 선생 말만 들어. 자, 오케이,
준비됐죠?
준비됐죠?
자, 페이싱 온. 자, 컨트라스트. 자,
오케이,
인플레이
인플레이 쭉. 하나, 둘, 셋, 넷, 다섯. 디플렛. 1, 2, 3, 4, 5.
Very nice.
오케이.
Korean con.
자,
1,
패싱
2,
업.
3, 4, 5.
오케이, got it.
James, are you singing too when you deploy the valve?
오케이, 됐어.
It's kind of interesting. It's
Yeah.
a Korean song.
I play.
오케이, 혈압 조금 낮추고.
No drums, right?
오케이.
SJ, did you teach them that?
자, 천천히. 오케이, 여기서 잠깐만 천천히. 자, 피그테일 조금 노줌하고 여기 피그테일. 오케이. Okay, and then tension release. And then also we prepared ice, and the ice is very nice. This patient is now doing the TAVR, the MEC, just the local anesthesia. And okay, 자 한번 혈압 괜찮지?
페이싱 와이어 뽑아도 되죠? 네.
잠깐만 페이싱 한번 리듬 보자.
Yeah. Please check the.
괜찮네, 그지?
Because
페이싱 안 들어가고 있지?
페이싱 와이어 can interfere
안 들어가고
the
있지?
ultrasound image
오케이,
at
플로로
the time
말고.
of ICUs. You
자,
have
그럼
to
페이싱을
remove
뺄게.
pacing catheter right now.
Okay, okay, got it. And then we will check angio, and then check ice quickly.
Yeah, Dr. Park, check
오케이,
angio
자
first.
엔지오를 한번
Yeah.
먼저 뽑아보자. 자 플로로. 자 준비됐죠? 자 엔지오 레디. 풀샷. Okay, looks good. Here's we're gonna check the ice, and now we adapting stage of the eyes. You know, the
Okay.
okay. 자, 플로로 왼쪽 거 밟고.
cardiac echo.
I mentioned before this patient at poor echo window. We have to consider other imaging modalities such as eyes or transect echo image. It's already it's just 1 month we started eyes procedure.
Yeah.
Please forgive my appearance today. I'm trying.
Okay. You know, as many operator already know, ICE has a very nice advantage compared to the another imaging transthoracic or TE. The ICE is
This is authentic thoracic aorta.
use a French. Just the primary operator can handle this procedure. ICE also does not require any general anesthesia, and the ICE is a very high resolution.
This is a long axis image of aortic valve.
오케이, 거기다 칼라 한번. 그죠?
Color 좀.
오케이.
The right side is ascending aorta.
Is there a short axis view of the aortic valve?
Yeah, I'll try later because we
We
changed the
cannot
catheter
clearly see
position.
the valve motion.
Yeah, I see.
Yeah, I think it would be helpful if they would explain a little bit, because I'm sure not all of us are familiar with ICE on TAVR.
It's a good challenge to. It's a very good demonstration for us.
Yeah,
Okay,
yes.
you can see the wire over there.
Wire over there.
Okay, this is a long axis.
Long axis image.
좀 칼라를 조금 와이드하게.
Color left side 옮겨주세요.
그렇죠.
Okay.
그렇지.
A little bit lower, slow positions.
There, it seems like there is no PVR
No
right
PVR.
now.
Okay, great.
Let's move to short axis right now.
Okay, got it.
For this patient, the short axis image is very
자, 칼라
challenging.
지워주고.
Yeah.
Great.
Actually, we have the one panelist of the imaging specialist
Dr. Hong?
among the panel.
Is there?
Is there any comment about the ICE image?
조금만 더 뺄게.
It looks nice, but I think its eyes have some additional benefit for intra-procedure monitoring. So we usually do the best position to see the heart silhouette, and especially the pericardial effusion
Good.
and long axis.
This is
So
left ventricle
even
view.
during the procedure, we can see the echo images.
There is no effusion
for
right
the
now.
Yeah, okay,
monitoring
great.
of the complication.
Just
that
to-
is
just
very
to see supply
helpful
wire.
for the
Yeah.
procedure.
Can you
So
see the
long
motion
axis
of the left
is
ventricle?
Yeah, it's
always,
good.
We can get good image, but short axis is sometimes
오,
very
파이널 찍으면
tricky.
되겠다, 그지?
Right here.
Okay,
We can
okay,
get a
great.
short
Yeah,
axis
it's
image.
good.
Yeah.
여기 한 칼라 좀 하면 되고.
Can you show me the
아,
color?
We're in the
tip,
TAVR
yeah.
with.
Yes, okay, over here.
I lost. It's very challenging for short axis image.
Yeah,
Oh, right here.
okay.
Yeah,
you can
please
see.
turn on the color
Okay.
flow.
What's the criteria of reimbursement for
Yeah,
eyes?
you know, some ICE is thoroughly reimbursed in our nation, and that there is another good advantage for use. Just the 이거 줌 다 풀고
좀 풀고 일단은
patient just paid $100 for use ICE, and
right here.
How
remaining
much cost for the probe?
uh,
2,000.
How much is
maybe?
it?
About $2,000.
2,000.
Yeah,
Yeah,
$2,000.
$2,000. The 95% reimbursed by government.
Yeah, right here.
Just 5%.
Can you see the surgery
Okay,
image of the
great.
valve?
Yes.
Yeah, it
There's
seems like a no leak at
wonderful.
all.
That's the reason why my taxes are increasing.
Right.
But patient payment is
Cost.
low.
Oh, okay.
Yeah,
Can you,
okay.
claims,
Good.
can you adjust the depth?
여기. So and this is TV, 그죠? Very flexible and so and
So I mean, I'm a layman here now. What I do see is a lot of moving parts, and I see a lot of tissue, but I really don't know what you're looking at. Can you teach us a little bit of what you're looking at and have a stable image?
On the
and
upper
say,
left side, you
this
can
is-
see
because
your
what you're doing
show
is
the X image right now.
what you're doing is you want to see the
Oh, this is
PVL,
pulmonary
I
valve, right
assume
side.
anyway.
This is pulmonary
yeah,
valve.
yeah,
Oh, so the right side.
yeah, right.
Yeah, right upper as a pulmonary artery, main pulmonary
Yeah,
bifurcation.
yeah, right.
Left side is aortic valve.
Yeah.
Can you? Yeah, third axis of the aortic
Oh,
valve.
great, wonderful.
Yeah,
Wow.
color please.
This is good.
Yeah,
Great,
very
great.
nice.
And could you show us the overlay with the color?
Ooh,
Great, great Doppler.
wonderful.
Not pretty
There
much.
is a advantage of the eyes. It's
Yeah,
very,
no recador right now.
Mainly central.
Yeah,
Okay, now
it's good.
yeah.
And then we're gonna finish this procedure, the final checking. 자, 좀 풀고 이거 뺄게. 천천히 빼고 파널 잘 한번 찍어볼게요. 조금만 더 뺄게. 자, 피그텔 올려야 돼. 자, 줌 다시 하고. 오케이. 자, 테스트 살짝.
다행이다.
오케이, 준비됐죠? This is a final shot. 오케이. Enjoy. Okay, just no AR, just trivial
Very
AR,
nice.
and then RAO. Okay, Angel, ready?
I view is better.
Full shot. Okay, good. So I think this is a very, the nice result, and 71 relatively young, the low risk patient. We shows a lot of things via the joint demonstration with the cardiac surgeon, and also shows the eyes advantage, and the result is very excellent. So any question?
Excellent job of the Dr. Kim, surgeon. Okay, excellent job.
Okay, thank you. Okay, thank you.